Okay, Assalamualaikum. Okay, kita mula kitab Al-Fatihah. Okay, let's start lah. So you guys nak buat macam ni present case kan? Okay, boleh present.
Alright. So I will start. So my name is Muhammad Nakib bin Mohsin and my matric number is 1812001. So this is my case. So the chief complaint. Hazim is a 14-year-old Malay boy with underlying type 2 diabetes mellitus.
Sorry. You guys buat slides Tak cik lah slides.
Oh.
Saya nak present macam sebab saat ni bukan lah. I thought you guys akan present proper presentation. Faham tak? Maksud you clap and then you present. So, kalau pakai slides tak cik lah slides. Tak apalah. Dah prepare slides. Continue je lah.
So chief complaint, Hazim, a 14-year-old Malay boy with underlying type 2 diabetes mellitus, diagnosed at UMMC 4 years ago, admitted to the pediatric ward because of poorly controlled diabetes mellitus and for blood sugar profile optimization. For the history of presenting illness, Hazim was initially diagnosed in the year of 2017 when he initially presented with polyuria, polydipsia, nocturia, and polyphagia. Hazim mentioned that during this time, his mother tried giving him metformin, and both of them observed a significant improvement in the symptoms. Subsequently, an appointment was arranged by his father at UMMC, and the diagnosis of diabetes mellitus type 2 was made. Upon diagnosis, Hazim was started with metformin and also non-pharmacological therapy, consisting of low-carb diet as well as weight-reducing exercise. He was initially obese on diagnosis, but he managed to lose about 20 kilograms in 2 years' time. However, in the past 1 year, he was unable to control his blood sugar level. After enrolling to a boarding school, he claimed that he was unable to catch up with the hectic school schedule while taking his medication, as well as miss follow-up at clinic kesihatan. That being said, Hazim had no sign and symptoms suggestive of diabetic ketoacidosis as well as HHS. There were also no episode of hypoglycemia for 4 years after being diagnosed with diabetes mellitus type 2, as well as 1 year of poor control of diabetes mellitus. Hazim has not shown any sign of complication of diabetes mellitus like recurrent infection, peripheral numbness, and blurring of vision. Previously, he had only checked his blood sugar profile at home, specifically his fasting blood glucose every day, except for when he was at the hostel. Hazim claimed to have checked his HbA1c level 3 times at June 2020 at 6.5%, in January 2021 at 8%, and few days ago at 13.6%. A day prior to admission, the patient checked his fasting blood glucose at home, and he was brought to suspect and admitted to pediatric ward for a close monitoring after his fasting blood glucose reached at 14 millimole per liter. So for the system review, for the general, the patient was alert, conscious, no jaundice, pallor, or cyanosis. The patient complained of lethargy, especially after playing sport. And for respiratory, for neurological system, the patient was responsive to stimulus and no fits. And there is no history of seizure or fainting. For cardiovascular system, there was no cyanosis, no ankle swelling, and no orthopnea. And for respiratory system, there is no shortness of breath, hemoptysis, or additional sound. For GIT, there is no abdominal distension, diarrhea, constipation, and vomiting. For genitourinary system, there is no hematuria or frothy urine. And for hematological system, no bruises, gum bleeding noted. And for musculoskeletal system, there is no muscle weakness or muscle wasting. And for past medical history, Hazim had never been diagnosed had never been diagnosed with any other disease prior to diagnosis of diabetes mellitus. This was his second admission. This was his second hospitalization. So the first one is at 2 years ago. He had been warded for nose surgery due to a frequent nosebleed. And for past drug history, he has been taking metformin since diagnosis was made, twice every day after brunch and after his early dinner. He would usually snack later at night. And for immunization history, he had completed his vaccination. And for birth history, the patient was born at term in HTAA via cesarean section. However, the patient cannot recall the rest of it. Next, for diet history, he take a low carbohydrate, low fat, and low glycemic index diet, 5 meals per day, and previously only 2 days per meal. Next, for family history, he had he had a strong family history of diabetes mellitus. Both of his grandparents from both of his parents' side have diabetes mellitus, and both of his parents also have diabetes mellitus, which were diagnosed at quite early age. And his father was diagnosed at age of 33, while her mother was diagnosed at the age of 36 years old after her last pregnancy. And Hazim is the first from 3 siblings. Both of his siblings currently are free from any disease, as well as no sign and symptom of diabetes mellitus. He is currently feeling the burden of being the eldest, such as according to him, always at fault, even it's not his. And for social history, Fazim is an active student at his school. He plays sports such as basketball as well as volleyball. He do not have any issue with his secondary school friends and teacher. However, he did mention about some of his primary school friends as well as teacher using his illness as a personal insult against his few years back. Currently, he claimed to be free from any teenager issues. Next. For physical examination, on general examination, the patient was conscious, alert, not in pain and not in respiratory distress, but he looked lethargic. There was the capillary refill time was less than 2 seconds with normal skin rigidity, no rashes or bruises noted. There is no jaundice and conjunctival failure, no sunken eyes, but lip was a bit dry. And the hydration status was good, but the hygiene is good. There is no central cyanosis, moist tongue, and there is no fasciculation. And there is also no injected and enlarged throat, no lymphadenopathy, no raised jugular venous pressure, no sacral and pedal edema were noted. For anthropometric measurement, the weight is 44 kilogram and the height of the patient is 151 centimeters. So the BMI is 19.3. 19.3, which is a healthy weight for the age at the 48th percentile for boys aged 14 years and 5 months. And then the vital sign, the temperature of the patient is 37, which is normal. The pulse rate is 120 beats per minute, regular rhythm and good volume. blood pressure is 86 per 59 millimeter mercury, which is normal, and the respiratory rate is 24 per minute, which is normal. And for respiratory examination, on inspection, the chest moves symmetrically with respiration. There is no chest deformity, scars or usage of accessory muscle when breathing. There are also no audible wheezing. And for palpation, the trachea was centrally located and no tracheal tube. The chest expansion and tactile vocal parameters were equal bilaterally. For percussion, there were resonant all around lung zone bilaterally, and in auscultation, the air entry equal bilaterally. There is a vesicular breath sound with no added sound, and the vocal resonance was heard and equal bilaterally at all zones. For cardiovascular examination, for inspection, there is no chest deformity, scar or dilated veins. For palpation, the apex beat was palpable at 5th intercostal space in the anterior axillary line. And for abdominal examination, in inspection, there is no distended and move. The abdomen is not distended and moves symmetrically with respiration. And the umbilicus was centrally located and flat. There is no scar, dilated vein, visible peristalsis or pulsation. And for palpation, the abdomen was soft and untender. The liver palpable 2 centimeter below subcostal margin, but spleen is not palpable. And kidney is not palatable. Percussion, there is no shifting dullness and fluid trill. And for auscultation, the bowel sound was heard. I think that's all.
Okay, cuba you pergi examination. Pergi slides awal-awal sikit. Lagi? Okay, jap. Lagi? Okay, belakang. Okay. So anyone got any comments? What's good about it? What good about the presentation? Anyone? So let's go to your first slide lah. Okay. So what's good about the presentation? Anyone?
I would like to comment.
So Afrina Ziyadi. Afrina betul. Adik Ahmad cepat.
Okay.
What's good about the presentation?
What's good? I think for the most part, the flow is nice. He summarized most of the things well. And I'm able to catch up with the flow. However, for the downside, some of the details are a bit unclear to me. For example, in the HOPI, there's a point where he said his mother tried giving him metformin during the initial diagnosis. So that's a bit. I was a bit unclear how his mother suddenly gave him metformin at the initial part. But other than that, the flow is nice. I think.
Jap. Amar ambil ni dia ambil entrance exam kan? Ke dia dah lepas entrance exam?
Rasanya dah lepas saya.
Dapat band berapa?
Tak sure.
Okay, sekejap lah. Okay. Okay, good. Adik Rishad. I think I can answer for your concern lah actually. Because the parents are on metformin. So Hazim's parents is on metformin. So basically, so dia ambil. That's when the mother give the medication to Hazim. Okay, Afiq Nasir. What's good about the presentation?
So in my opinion, the presentation the flow was good. In this case, it's a bit straightforward because we have already know the diagnosis because the patient is already diagnosed with type 2 DM. So I think in the presentation, he tried to present about the diabetes quite good. All the details such as the complications, any symptoms, any medication taken, is there the compliance of the medication of diabetes mellitus. So yes, the HOPI is pretty straightforward because or we already know the diagnosis. For the downside, I think it's because of like Afina just said, it was at the beginning his mother tried to give metformin, so it's a bit we don't know why he straight give metformin to the patient.
Itu buka page first page tadi. First slides. Okay, what can be improved? Anyone else? Afika, Atira? What else can be improved?
I think everything has been said by my colleague just now.
Okay, good. Okay, so in general, I would expect a better, this is very good lah. Of course, the presentation is already complete. It's quite complete, structured, and okay lah. It's good lah. It's good. In general, it's good. However, I'm expecting more lah because this is you just read out from the slides, kan? You've got ample time to prepare the slides. So I would expect. I'm expecting a better. This is already good, but a better one. So what you can improve actually, if we go through the slides again, kan? Okay. The intro is very good lah. You brief us the background of the patient, kan? The diabetes, the diagnosis. As your colleague mentioned, quite straightforward. We've got the diagnosis already, kan? And then cuma HOPI though. So patient was actually, this is a planned admission because of for BSP optimization. So how was he doing at the day of presentation? You did mention you thought slides after this. Okay, yang tadi. Okay. Actually, and better. Because for HHS and DKA, they've got a specific sign now. Contoh, for example, kan, you boleh mention at your level, kan, you should mention like this. There's no features, there's no signs and symptoms suggestive of DKA, such as apa dia sign and symptoms of DKA? Apa dia?
Comorbidity.
Comorbidity, okay. Before that, comorbidity tu teruk sangat dah, biasa koma dah. Before that, usually they get abdomen lah, abdomen vomiting. That's the features of DKA lah, abdomen vomiting. Lepas tu smelly breathing macam tu. That's the typical early sign of DKA. Bila dia dah comorbidity tu dia dah koma biasanya. Okay. And then HSS. Apa dia punya features HSS? HSS ni biasanya dia dah reduce conscious level. Dia dah altered behavior, altered conscious level. So before that, dia kalau poor control, what are the signs and symptoms of poor control diabetes? Dia ada symptom and signs of hyperosmolality, faham tak? Hyperosmolality. Sign and symptom of hyperosmolality, which is apa dia?
Polydipsia.
Polydipsia, polyuria, weight loss. Patient ni actually what concern us when he presented is weight loss. Okay, when he presented, he was fasting. So we took the fasting blood sugar was 18. Okay, fasting blood sugar was 18. And then they claimed they had a weight loss. Significant weight loss in the past 2 months. So that should be in your HOPI. Okay, weight loss. And then you can mention there's no polydipsia, there's no polyuria. Because the fourth paragraph is only the complication kan, long-term complication. But acute presentation you tak mention lah in your HOPI. Okay, apa lagi? What else can be improved? The rest I think very good lah. You include the diet history, the medication history, and then the significant family history kan, young onset. At presentation kan, you mentioned that yang he was initially obese. Kenapa we diagnose him as type 2 DM?
Ada tu, he was initially obese on diagnosis.
Macam mana apa dia?
I mention tadi. Dia initially obese on diagnosis, but he managed to lose about 20 kg in 2 years time.
Okay, good. Okay. Yang lost weight tu I dengar tapi obese. Okay. So good lah. So you kena mention kenapa we diagnose type 2 DM. So basically because they're obese lah. Dia datang dengan obese. Dia ada. And then you kalau bagus, it's better untuk you mention the complication, early complication macam the cholesterol level, the BP at diagnosis. Okay, faham? Okay lah. And then the rest is okay. Cuba pergi examination. Okay, so examination what in DM kan, especially DM young onset DM kan, budak-budak DM. What are the features yang you kena tengok, yang you kena mention in your examination? Kau keksik dia tak adalah keksik. You tak tengok dia tak keksik lah budak ni. Okay, and he doesn't look lethargic pun. Anyway, so apa feature yang you mesti kena mention dalam you punya examination of DM? First ialah dia punya growth lah kan, dia punya growth kan. Dia lean ke, dia fat ke, obese ke, central obesity ke. Yang tu definitely you kena mention. Okay, itu number one. Lagi apa you kena mention lagi? Very important you kena mention. In fact, one of the most important. Apa dia? You kena mention, bila you examine patient, you mesti kena, patient DM, you examine, you mesti kena look for this sign. Apa dia?
Acanthosis nigricans.
Acanthosis nigricans kena ada, mesti kena ada. Doesn't mention anything here lah. You tak mention tadi, I tak dengar apa.
Tak mention.
So, mesti kena ada acanthosis nigricans, okay, because that's very distinguished features of type 2 DM. And this patient, apparently dia tak ada acanthosis nigricans, which is surprisingly, dia tak ada acanthosis nigricans, despite the insulin level is very high. Patient ni insulin level dia 34 tau, 34. Normal insulin level biasa 2, 3 macam tu je. It shows that the insulin there's a lot of insulin, but resistance. There's a lot of resistance to the insulin, towards insulin. So that's why there's a lot, but it's non-functioning. So this child we would expect got massive grade 4 punya acanthosis nigricans, tapi dia tak ada. So that's very important. The rest, and at your level kan, as third years, even doctors pun, houseman, MOs, you have to examine fully lah, all the system. Okay. Especially neuro exam kan. Macam you tahu patient yang tak ada neuro punya complication. Neuro exam pun tak ada. Faham tak? You guys dengar tak? Apa neuro exam yang paling penting sekali you kena buat kat patient DM? Kalau I bagi you patient DM, I kata, okay, examine this patient neurological function. Okay, neurological system.
Sensory
So what?
examination.
Apa dia?
Sensory examination.
Sensory kan. Sensory is most important lah patient DM. Especially apa? What is the first yang dihilang patient DM?
Sensation dekat food stocking
The
distribution.
glove and stocking kan. The glove and stocking distribution. Lagi apa lagi yang dihilang first kali? Actually the first yang dia akan hilang is proprioception. Okay. Dia bukan nociception dulu. Dia proprioception dia akan lost dulu. So patient DM dia akan lost proprioception dulu. Joint positioning. Lepas tu dia akan lost the nociception. The temperature and pain. Lepas tu dia akan ada glove and stocking distribution. So proprioception is very important. Proprioception means dia punya joint positioning, lepas tu pressure dia satu. Satu you guna apa? You guna apa? Apa yang guna? Monofilament kan? Untuk check pressure kan? Deep sensation tau, bukan superficial pain. Deep sensation, pressure. Okay. So tu cukup. Yang lain tu okey je lah. Ada soalan? So what is your conclusion? Siapa yang present tadi lupa?
Saya tu.
Okay, so what is your conclusion? You kena conclude lah you punya presentation.
Alright. It's a case of a 14-year-old Malay boy with underlying type 2 diabetes mellitus that admitted to pediatric ward because of early control diabetes mellitus. He has no sign and symptom. He has not shown any sign and symptoms for DKA as well as HS.
Okay. So your diagnosis?
Diagnosis fully control diabetes mellitus type 2.
Secondary tu?
Secondary to
Kenapa control dia tidur tak bagus? There's a lot of reason untuk control tak bagus type 2 DM.
okay. Secondary to apa?
You dah present panjang lebar dah. Second tu non-compliant kan, non-compliant to medication. Actually dia multifactorial lah. In this case I would say it's multifactorial. Okay, number one is patient is non-compliant, tu number one. Number two is patient is attain puberty. Faham tak? Bila you attain puberty, you memang akan lost control punya sugar. You punya sugar control akan become poor. Kenapa? And you insulin requirement will need to be adjusted. Kenapa? Kenapa puberty tak bagus untuk DM? Anyone can guess?
Hormonal changes.
Apa? Which particular hormone yang affect? And how the hormone affect the sugar?
Is it growth hormone and sexual hormone?
Yes, so basically growth hormone and sexual hormone will affect ni. So growth hormone and sexual hormone, actually most of your hormone in your body is a anti-insulin hormone, faham tak? Basically in your body you can divide hormone into two groups, insulin, pro-insulin and anti-insulin hormone. So all the hormone, the main function, one of the function of all of your hormone is to counteract the action of insulin. Insulin is the most powerful hormone in your body. It's very powerful. Okay, semua hormon lain dia akan counteract insulin punya effect. So insulin dia reduce human sugar. The other hormone dia memang increase sugar. Thyroid hormone, growth hormone, sex hormone, cortisol. These are hormone yang memang dia punya action dia akan increase punya sugar. So bila you ada puberty, you ada spike of sexual hormone and also growth hormone. So you akan reduce you punya insulin sensitivity. That's why orang in puberty, the insulin level akan increase. Sebab dia akan less sensitive to their insulin. So I would expect this patient, the diagnosis would be poor control diabetes, secondary to multifactorial. Number one would be the poor compliance, and number two is puberty lah. Okay. Okay dah, next. Ada soalan? Ya, ada soalan tak? You guys cuba aktif sikit. Ada soalan?
Doctor, I would like to ask.
Okay.
So from the history, I've noticed that the family history of DM is quite strong because there is both of his grandparents have DM, both of his parents also have DM. So my question is why the patient is not diagnosed with modified onset of diabetes.
Modified onset.
The maturity onset of diabetes of the young. Why the patient not? Why the patient is not?
Why kita tak diagnose MODY? Because MODY, there's a clinical criteria untuk you diagnose MODY, okay? And also diabetes we diagnose clinically. It's not necessary for you to do blood test or genetic testing untuk diagnose. Most of diagnosis is made clinically, except for monogenic DM lah, macam MODY ataupun congenital DM, and then you kena diagnose either traditional atau permanent, you kena diagnose confirm by blood lah. Tapi by clinical you boleh there are clinical features that suggest patient ni dia start dengan obese, dia memang obese, strong family history which is very typical of type 2 DM. Type 2 DM also strong family history. Dia sama je macam MODY. So MODY is autosomal dominant. So dia memang you akan nampak every generation akan ada. Tapi in this family, both parents DM. And which is not typical of MODY lah. MODY biasanya either mother atau father. Tapi kalau both parents DM and both grandparents DM, usually this is a features of type 2 DM lah. Nurturing punya effect. The environment punya influence on the disease pathogenesis. Faham? Maksud dia, the family memang, both family ni memang gula punya family lah. The sweet tongue punya family. Faham tak? So nampak macam, so DM memang DM pun is a strong family history, DM. You are the parents, both parents DM, chances untuk dapat DM is almost 70% kot. Okay, just as strong as MODY. In fact, maybe more than MODY. So MODY, one parents DM, then is 50% lah. Tapi kalau both parents DM is also, kalau both parents DM, MODY, both parents MODY, your chance is about still 50% juga. Tapi kalau one parents MODY is 25%. So it's less daripada type 2 DM. Okay. And then representation dia memang obese. So MODY usually tak obese. Usually they are not that obese. Okay, pasal ada feature-features lain. Okay, but of course you should put MODY in your differential lah, and then you confirm by blood investigation. Okay, ada soalan lain? Faham kan?
Okay, faham Doctor. Thank you.
Cuma the only things yang quite atypical is acanthosis nigricans, which is absence lah. MODY biasa tak ada acanthosis nigricans, tapi type 2 biasanya ada, tapi in this case dia tak ada lah. Okay, ada lagi soalan? Okay, next presentation.
Assalamualaikum warahmatullahi wabarakatuh. My name is Wana Syazwani binti Yusuf, matric number 1816982. Today we'll be presenting a case on viral fever. So the chief complaint, Yusuf, a 7-month-old Malay boy, presented to the emergency department of Sultan Ahmad Shah Medical Center due to fever for 3 days duration prior to admission. So for the HOPI, Yusuf was apparently well until 3 days prior to admission, where he developed fever. It was sudden in onset. The fever, however, was not associated with chills and rigors. On the first day of onset of the illness, the documented temperature at home was 39.7 degrees Celsius. His mother gives paracetamol for hourly and bathed him frequently, but the fever did not seem to resolve. Okay. On the second day of onset of the illness, the temperature documented was 38 degrees Celsius. The parents then decided to take Yusuf to Clinic Al-Farabi. And at the clinic, the GP found that Yusuf's throat was reddening. Yusuf was also then given antibiotic by the general practitioner. On the third day of onset of the illness, Yusuf was then brought by his parents to the pediatric specialist clinic. Due to dehydration, Yusuf was then given a referral letter to SASMED. Okay, so on the fourth day of onset of the illness, then his parents brought Yusuf to SASMED. At the emergency department, Yusuf's temperature was recorded as 38.1 degrees Celsius. Blood, FBC, renal profile, C-reactive protein, and venous blood gases was also taken at ED. He was also given a suppository paracetamol at ED. Okay. Next, the fever was also associated with vomiting. The vomiting occurs at second day onset of illness. It was a post-tussive emesis. The vomiting also occurs 3 to 4 episodes per day. The content of the vomiters are milk and porridge. And during the first day of the admission at the SASMED, he already vomited 2 times since morning. Other than that, Yusuf was also having diarrhea. The diarrhea also takes onset on day 2 of the illness. It was watery in nature. It happened 2 to 3 episodes per day. It was profuse and mucoid in nature. There was, however, no blood observed in the stool. The color of the stool was yellow and smelly. And then the mother noticed the diarrhea to become blackish greenish after the antibiotic and does not have any foul smelling after that. The mother isn't sure of how frequent she changed the diaper at first. However, she claimed that the stool was overflowing. On the second day of the admission, she claimed of diaper change for a total of 6 times per day. She claimed that use of normal bowel output is usually once in 2 days. Yusuf also experienced ulcer in his mouth on day 2 of onset of illness that was noticed by his mother. He wasn't given cream to treat the ulcer. However, no further information is obtained about this. Due to the illness, Yusuf's mother claimed that he has reduced in oral intake and loss of appetite. He refused both solid food and breastfeeding. He also has reduced urine output. Due to this, his mother changed the pampers for past urine only 2 to 3 times a day. Normally, this will take 6 times per day. On the day of the clerking, which is the day of the discharge, Yusuf did not experience any symptoms anymore. Yusuf lives in a dengue-prone area, which is in Tok Sirah. There's monthly fogging in the housing areas. His mother denied Yusuf contact with any person under investigation of COVID cases. She claimed also there is no Hari Raya visiting. Yusuf was sent to the nursery before the fever occurred. His mother is unsure of any sick contact at the nursery involving the caretaker or the other children there. There's also no other family member having the same symptom as Yusuf. There's also no history of runny nose and cough. There's also no history of rashes, no symptoms of upper respiratory tract infection, no rapid breathing. There's no abdominal pain. His mother also denies any water activities and any travel history. So, okay, for the systemic review, in the cardiovascular system, there were no heart murmur, cyanosis, or reduced effort tolerance. In the respiratory system, there's no cough, wheeze, or breathing problem. Neurological system, there were no seizures or any abnormal movement. Hepatobiliary, there was no yellowish discoloration of skin or sclera. Any pale colored stool or pruritus were noted. Musculoskeletal system, there were no limping or swelling and no disturbance of key. For the past medical and surgical history, this is the second admission to ward. The first admission was due to neonatal jaundice for 5 days. His neonatal jaundice went up to 3 weeks, which later was treated at home. Yusuf also had no surgical procedure done before. Okay. For the antenatal and birth history, he is the first child. Antepartum, the mother is in good condition. She had no any gestational diabetes mellitus or group B streptococcus infection. However, she has low hemoglobin with count of 10. Intrapartum was born term at 37 weeks 5 days. He was then delivered via spontaneous vertex delivery at Tasman. His birth at weight is 2.6 kilograms. However, there is no complication phase. Postpartum, Yusuf had neonatal jaundice, which requires him to be treated 5 days at hospital. Another 3 weeks, he was only treated at home. For his immunization history, his immunization is up to schedule in accordance to the vaccination schedule by Ministry of Health. No history of missed vaccination or added vaccination apart from the schedule, and no allergic reaction following the vaccination. In the nutritional history, he was fully breastfed until 6 months. He then started weaning starting 6-month-old, which he eats porridge with carrot and some mineral water. Developmental history is appropriate up to his age. In the growth motor, he can sit without support. Fine motor inhibition, does a commandocra. Speech bends or shakes toys, attempts to hold object in each hand. Social, imitates speech sound. Drug and allergy history. During his this illness, he has taken antibiotic given by GP at day 2 of illness, and also paracetamol given. He had no known drug allergies. For the social history, Yusuf is the only child for now. Yusuf lives in Tutsira with his parents and one uncle. Mother works in UMP. Meanwhile, Yusuf's father is self-employed. The house was completed with basic amenities, and they live in a dengue-prone area with a monthly fogging done. For the general examination, the child was alert and conscious, was comfortable sitting on the bed. The child was not tachypneic or in respiratory distress. He looked pink, active, and good hydration status. No dysmorphic features. The head size and shape was normal. On peripheral examination, no finger clubbing, peripheral sinuses, any pulmonary erythema, smith hemorrhage, colonychia, gluconychia, oscillatory node devolution or spider nevi. Capillary refill time was less than 2 seconds. Radial pulse was palpable with good volume and regular rhythm. No pallial jaundice, central sinuses, lymphadenopathy, and rashes. No nasal and ear discharge. On examination of mouth, the tongue was moist and the tonsils were injected. No exudate was present. The oral hygiene was good. No pedal edema was noted. On the respiratory, for the vital sign, respiratory rate 34 beats per minute, heart rate 121 beats per minute, blood pressure 90/53 millimeter mercury, temperature 36.4 degrees Celsius, afebrile, and oxygen saturation 100% in room. Okay. anthropometric measurement, weight is 6.7 kilogram. However, their height was not obtained, so it cannot count for the BMI. For the abdominal examination, on inspection, the abdomen was not distended and moved symmetrically with respiration, no dilated vein, caput medulla, visible pulsation or surgical scars. The umbilicus was centrally located and inverted. On palpation, abdomen was soft and non-tender. No hepatosplenomegaly noted. The kidney was not palatable. No shifting dullness noted. And on auscultation, normal bowel sound was present. On the respiratory examination, on inspection, chest moves symmetrically with respiration. No surgical scars or dilated vein noted. Chest was also normal in shape. Trachea was centrally located on palpation. The chest expansion also equal bilaterally. On percussion, both lungs were resonant. On auscultation, equal air entry and vesicular breakdown was heard. On CVS examination, no scars, bulging, visible pulsation or dilated vein at the precordial area during inspection. The episode was palpable at fifth intercostal space. No thread or parasternal is palpable. First and second heart sound were heard. There were no murmur or additional sound noted. On inspection, no muscle wasting or fasciculation noted. Muscle tone and power were normal in all limbs. Tender reflexes were normal and equal bilaterally. The sensory was intact and cranial nerve examination was normal. I think that's all.
Okay, that's all.
Yep.
So summary?
Summary. So, a 7-year-old Malay boy presented to the emergency department due to fever for 3 days duration prior to admission. He was presented with a other than fever, he also presented with vomiting, diarrhea, and also ulcers that was noticed by his mother. Due to the illness, he also had reduced caloric intake and loss of appetite, which may lead to dehydration.
So in conclusion, the diagnosis?
Viral
Diagnosis
fever.
now.
Oh, my provisional diagnosis would be viral fever with parenteral diarrhea.
Lagi? Differential diagnosis?
Acute gastroenteritis, and also maybe food poisoning or any dengue fever, but yeah, dengue fever may also be.
Food poisoning boleh? Food poisoning.
Excuse me?
Food poisoning boleh ke?
I think it can be one of the CDS.
Unlikely lah kot, I rasa. Sebab dia tak adalah prominent GI symptoms kan. And then fever for 5-6 days ni tak macam typical of food poisoning. Okay, okay, good. So anyone? What went well? Start dengan Afika Atira.
What went well? The chronology is in order. However, I think for summary, it needs to be improved in terms of she didn't summarize the physical examination, and also this one just for provisional and differentials. Maybe she can also present the points for and points against.
Okay, good, good. Okay, anyone else? Aida Sabrina.
Okay, so what I think is good, tone is great, flow is also great, ShapiI is also quite detailed. and she included relevant negative findings. So what can be improved is that I think for chief complaint, she was referred due to dehydration, right? Maybe you can include that in the chief complaint. And then she didn't mention the symptoms of dehydration that made the patient being referred to SUSMED. Also, the HOPI is not in chronological order, as in like what exactly happened in day 2, because day 2 there were like vomiting, diarrhea as well, and tapi she put it dekat bawah at the bottom. And then I think she also missed some important points, such as the name of the antibiotics given, as well as the cream given for the ulcer. And I think she didn't rule out symptoms of meningitis, for example. That's it. The overall is great.
Okay, good. Okay. Okay, look at Niyatil Husna Mukhtar.
Okay. So far, for the positive comment from this presentation, I would say I understand the main problem of this patient. However, like I just said just now, the flow kinda apa ni not in chronological order, and I would like to add on also like there's like I confused because the from the HOPI, the more likely presentation is more towards dehydration than due to the fever. So I'm kind of confused about that. However, for I think that's all. Mostly about the flow.
Okay, good. I agree with all the comments. I think the flow is good. Okay, the flow, I think it's okay lah. The flow is okay in terms of presenting complaint, presenting complaint, and so on and so forth. Kan? Sekejap. Ada tetamu. Okay. So, the point that I really interested is the one mentioned by Niyatil Husna. The HOPI kan. Usually lah kalau the child dah datang fever dah multiple days kan, 3 days fever. Fever is rarely the presenting complaint lah. It's rarely the presenting complaint. Unless kalau this is something yang acute and then the tiba-tiba spike. Itu mungkin lah. But usually the reason presenting complaint is usually macam reduce oral intake, lethargic. These are the presenting complaint. Faham tak? So I will focus on that as presenting complaint rather than fever. Fever should be dia punya lah, ada comorbids lah, ada presentation which is fever lah. But presenting complaint, I think this child is actually reduced oral intake atau lethargic, less active. Okay, so you elaborate on that lah on your HOPI. Lepas tu you tak mention rashes kan? You ada mention rashes ke?
No rashes.
You sebut je no rashes. Takkan dia tak sebut rashes. Kan? Saya tak ingat lah. Saya tak sebut rashes.
Sebut
Ada,
tadi
ada.
doktor.
Ada Okay lah. Anyway, so fever with rashes is very important lah. Baby yang patient yang tak complete lagi immunization, rashes history should be asked. Okay, you should present on rashes. There's no rashes. Atau kalau ada rashes, then you should elaborate on the rashes lah. Because that's one of the main differential diagnosis. Otherwise, saya rasa yang lain tu okay juga macam your friend sebut. Sebab this is quite typical lah, quite straightforward. Viral fever kan. Cuma ideally, our aim is always to identify what is the virus. Rather than viral fever, virus can be anything. So, this shall, I agree it's quite difficult lah untuk pinpoint what is the virus lah. Cuma from investigation kita tahu dia punya ALT, liver transaminase macam slightly increase. So we think this might be viral hepatitis lah. One of the differential. Cuma definitely in your case you tak tahulah dia investigation. And then you pun tak mention whether dia jaundice ke tak kan. You tak mention in your exam whether dia jaundice ke tak. Cuma yang satu kan, definitely you kena rule out and rule in diagnosis kan. You kena mention things that support your diagnosis and things that rule out other differential diagnosis. Tapi kan, in exam, in your clinical examinations kan, ataupun in your history, you should not just simply include everything in your history. For example, macam you punya examination, you sebut there's no apa you sebut tadi? It's okay lah you nak sebut pasal IE punya symptoms kan. There's no osseous nodes, general lesion, splinter hemorrhage. Tapi you won't be penalized kalau you tak mention this. Okay. Sebab is IE in your differential? Tak kan? So bila you present, you kena masuk dia dalam you punya differential, faham tak? You include things in your differential, benda yang you mention in your clinical exam and also history. So bila exam you banyak focus on IE punya features, which is IE usually is occurred in a child with underlying congenital heart disease. Kan? Patient ni satu dia never diagnosed congenital heart disease. And then you punya CVS examination pun tak ada murmur. So usually you tak perlu present pun IE features. Kalau you nak sebut, you boleh sebut lah. There's no features suggestive of IE. Tapi you tak perlu sebut genuine lesion, osseous nodes. You tak perlu sebut all that. And then you sebut juga apa you mention, cuba tengok slides tu. Examination ni. Yang tadi. Ni caput medusa. Yang tadi depan lagi. Okay, tu ni. Spider nevi. Unless kau patient ada jaundice. Kau patient jaundice, then you boleh sebut. Tapi you tak sebut pun ada no jaundice. Kan? Okay, faham tak? Unless you suspect this is something yang hepatitis lah. Contoh patient datang dengan steatoria kan. In your history ada steatoria. Then you kena mention lah patient no jaundice. And then disebut tak ada spider nevi. Okay, faham tak? Because it shows that you just letak je semua benda. You won't be penalized lah. Of course, in exam you won't be penalized. Tapi it shows these are the things that differentiate between very good student and good student, ataupun excellent student and good student. Okay, faham? You include and exclude things that are important and give you information. Because if not kan penuh sangat, tapi actually tak banyak pun yang give change the management ataupun give a lot of information. Okay, faham tak? Okay, otherwise the rest I rasa okay je. I rasa okay lah. Because the case pun macam quite simple. Tapi I rasa okay je lah. Okay. Okay, any other questions tak? Any questions? Tony, you saw what's all.
Doktor nak tanya balik yang pasal chief complaint tadi doktor. Doktor kata the patient rarely came with chief complaint of fever. So kalau biasanya patient came with fever, dia akan cakap apa doktor? Fever with pressure ke dia couplekan fever with pressure ke fever with...
Okay, dia kan presenting complaint kan. I'm sure kalau you parents saya rasa tahu kot. This motor experience lah. Usually parents yang akan kata, oh datang sebab apa? Oh datang sebab demam. Tapi kan bila tanya dia kata, oh dah 3 hari demam. So kenapa 3 hari demam baru datang hari ni? That's the question you have to ask. Why today, not yesterday, not 2 days ago? That will be the presenting complaint. So dia akan kata, oh dia demam dah 3 hari doktor, tapi hari ni demam dia makin panas. Yang tu tak apalah. Then you punya presenting complaint would be spike fever. With 3 days. So you punya presenting complaint is parents came in with a complaint of worsening fever. Faham tak? Bukan fever. Fever would not be a complaint. Jarang lah complaint. Unless kalau dia day 1 of illness dia datang. Then the complaint would be fever. Tapi kalau dah day 3 fever 39 and then tiba-tiba datang, you kena explore betul-betul kenapa dia datang. Presenting complaint is very important sebab if you don't tackle the presenting complaint, then patient will not be satisfied and you are not treating the patient. But rather you are treating yourself. Contoh macam ni kan. Contoh patient tu anak dia dah demam 5 hari. And then dia datang because tapi dia datang because today anak dia complain of joint pain ataupun anak dia become more lethargic. So anak dia pun datang. Dia kata, oh datang sebab apa? Oh, fever. Anak saya demam. Tapi you fail to explore in detail lah. You fail to explore the concern, the ideas, their expectation. So what happen is, actually the main reason for admission is because lethargic atau poor intake kan, atau weight loss. So what happen kalau you thought the presenting complaint is fever, bila patient febrile you discharge. Tapi the main concern of parents is contoh weight loss ataupun lethargic. Tapi contoh patient masuk ward dah 48 jam tak demam, so you discharge lah kan, saat no fever. Tapi actually the main concern is lethargic. So dia tak akan happy, dia akan datang balik. Faham tak?
Faham betul.
So it's okay untuk you tak fever, tapi you have to guide parents. You have to clarify because some people kan dia tak boleh nak express dia punya, they are not sure and they cannot express dia punya needs or dia punya expectations. So that's why this is the role of doctor. Because sometimes you may think that thing is significant, but it may not be significant in the eye of your patient. Contoh lah, I always tell this to my student lah. I've got patients kan, I've got families yang I tahu dia ada 2 anak leukemia. Okay, and dua-dua meninggal leukemia, one after another. Very sad lah. Tapi I remember very close family of mine lah yang I kenal. Waktu anak dia first kena leukemia kan, the first child yang kena leukemia tu, we all concerned lah saat kena chemoterapi and then ada first relapse. Tapi bila I talk to the father kan, okay, what is your main concern? Tahu tak apa jawapan ayah dia? You agak apa jawapan ayah dia? Anyone can guess?
Complication of leukemia.
Complication of leukemia, okay. Such as? Specifically? Lah concern ni mesti lah spesifik kan, dia tak adalah concern. Rasanya apa yang ayah dia paling risau sekali? Matilah kan, biasalah. Biasanya orang cancer mesti lah risau mati kan. Oh boleh tak anak saya survive? Oh boleh tak anak saya sembuh? Nanti kemoterapi apa jadi kat dia? Apa side effect kemoterapi? Macam tu kan. Tapi the father kan, the main things yang father dia concern about is, boleh tak anak saya dapat anak? Dia akan jadi mandul lah. Tu benda yang soalan yang dia tanya. Which I'm very surprised. Anak dia dah relapse sekali and that's the question yang dia tanya. And apparently anak dia pass away lah. And then lepas tu dapat baby baru, the baby baru pun dapat leukemia juga. Which is very sad. Tapi that's why, so in this kind of, so if you fail to tackle the concern of patients, which is reflected by the presenting complaint, then you are not treating the patient lah, faham tak? Because we are treating patients and parents. Kalau pediatric ni you are treating, you treat the whole family. So things might, things that is not matter for you might be matter for them and vice versa. Jarang lah kalau patient dah 3 hari demam, kenapa dia datang hari ni? So, the kenapa tu will be the presenting complaint. Unless kalau memang mak dia kata tak ada benda lain, demam je. Then tak apalah. Then demam lah. Tapi demam pun you have to clarify. Is it because worsening fever or persistent fever dah 2 minggu atau dah 5 hari dan persistent? Then that's why dia datang. There's no other new symptoms. Usually presenting complaint is something yang new, yang acute, yang very acute, super acute. Yang tu yang buat dia datang. Okay, faham?
Faham. Thank you.
Okay, ada soalan lain? Okay. Ada soalan lain? And summary, just improve lah on the summary. Summary tu, you should include in your summary things that will help you in your diagnosis. The rest you tak payah mention pun tak apa. Unless it's something yang rule out your differential diagnosis. Okay, otherwise you tak perlu mention lah the rest. Okay, ada soalan? Ada soalan tak?
Doktor,
Eh,
satu
dengar tak?
soalan.
Apa dia?
Untuk presentation kan doktor, untuk systemic review dengan systemic examination, let's say patient tu dia tak ada apa-apa finding langsung pun dekat dia punya tu, tak ada any remarkable findings dekat systemic review and systemic examination. Lepas tu macam mana kita nak present bagi, sebab semalam saya present, sepatutnya saya tak present dua ni sebab tak ada apa-apa findings. Lepas tu doktor cakap at least kita kena present juga the snippets ataupun benda-benda, at least kena present sikit-sikit walaupun tak semua. Jadi saya tak tahu apa yang penting nak kena.
Okay, benda yang penting you can present, okay, benda yang you cannot miss is the sign and also symptoms yang support your diagnosis and exclude your differential diagnosis. Contoh patient datang sebab demam saja, tak ada benda lain, demam saja. So kenapa dia demam? So you kena think of kenapa. Okay, what are the differential diagnosis kalau patient datang demam je? Could it be dengue? Kan, kalau dengue then you kena katalah apa, there's no fever. Kalau you could think of dengue kan, you can sebut there's no retroorbital pain, there's no vomiting, diarrhea, there's no bleeding tendency. Okay, faham? On examination, you can look for that. Okay, contoh macam patient ni kan, you think this is Kawasaki, contoh kan. Then you can mention dalam examination you, despite it's not something yang typically you search for, tapi because you're thinking of Kawasaki, then you can mention, oh, there's no BCG scar induration. You can sebut something that specific. Atau there's no strawberry tongue. Because in usual examination, kita tak sebut pun strawberry tongue kan. Tapi that shows that you are thinking. There's no strawberry tongue. There's no cervical lymphadenopathy. There's no extremities, disclamation over extremities. There's no edema over extremities. There's no rashes. In fact, rashes kan, you boleh sebut. Kalau contoh patient ni, you rasa patient datang dengan demam je. And you think this is typhoid. Sebab dia history of, contohlah, dia ada minum, guna air telaga dekat rumah. Then you boleh sebut, there's no raw spot on the chest. Faham tak? I'm asking your question kan? Ke salah faham?
Betul. Faham, tapi kiranya kalau systemic review tu kita tak payah go through satu-satu ke? Kita summarizekan je.
Yes, you summarize je. Contoh kan, systemic reviews. Oh, you tanya pasal systemic reviews. Okay, systemic reviews is something new to me lah actually. Okay lah, so systemic reviews ni, you kena mention, kalau systemic reviews, apa yang you kena mention is anything yang might be complication of your diagnosis. Contoh kan, contoh you diagnose patient ni, contoh you rasa patient ni datang dengan rashes, purpura, datang dengan purpura and joint pain. So you think this is HSP. You're not calling purpura kan? So in your systemic examination atau in your systemic reviews you kena sebut apa complication, apa GI complication of HSP. yang you expect? Interception kan? Bowel perforation kan? Mesenteric ischemia. So you can mention. So in your systemic reviews, you can sebut, oh, there's no bloody diarrhea. There's no blood in stool. There's no abdominal pain. Okay. Systemic reviews abdomen lah. Kalau tempat lain you boleh sebut neuro exam, you just sebut neuro maybe tak related, so you sebut. However, neurologically there's no neurological was unremarkable. Neurologically unremarkable. Macam tu. Ataupun, and then in your exam you can sebut lah. On abdominal examination, there's no mass palpable. There's no olive mass. There's no mass palpable lah. Ataupun interception. Ataupun there's no rigidity, board-like rigidity. There's no rebound tenderness. Macam tu lah. Faham tak? So all your examination, because at the end of clerking, at the end of the clerking, your aim should be you get the diagnosis, you rule out all the differential diagnoses, and you identify any complication or possible complication. Okay, faham tak? I tak tahu I jawab soalan tak, tapi I rasa macam jawab.
Faham?
Am I answering your question?
Yeah.
Oh, okay. Okay, ada satu soalan last ke? So, pukul 10 ada meeting. Any soalan? So you guys masuk what esok next week
InsyaAllah.
Okay lah macam tu. Okay lah, kalau tak ada soalan, kita stop lah kot. Okay. Tapi remember lah, you tak perlu sebut everything tau. You don't have to mention everything. But you have to mention things that will tell your audience that you are thinking. Tu the most important to me. Okay. Any of my students yang present, they have to show that they are thinking. You have to show that you are thinking. If there's no element of thinking in the presentation, contoh lah, you mention semua benda. Everything under the sky you mention. No. Definitely you get the target kan. You will get the target lah. But that doesn't sound wise lah. It doesn't sound brilliant. It doesn't sound clever lah. It does sound like a robot, you know. So make sure your presentation have elements of thinking, because that's what we want from doctor lah. Because later on kan, in your future career, you akan jumpa doctors yang patient datang kan one symptoms, ambil semua investigation. Patient need to pay all investigation yang to learn all the differential diagnosis. Macam tu senang lah. Tak je doktor tak apa. Faham tak? You so nurse pun boleh buat. Ambil semua je zarah dalam dunia ni, and then what you'll get one of the target lah, and then you get the diagnosis. Ataupun hit with all antibiotics. Datang je bagi broad spectrum. You tak fikir lah macam tu, tak je doktor. Faham tak? Okay, faham? Okay lah, tu je ada start bebel. Okay, tertanggung atas speaker Farah dan suatu nas. Okay, assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum. Thank you,
so much, Doctor.
Doctor.
Thank you, Doctor.